Hello, and welcome to this Clinical Care Options podcast. I'm Nicola Hampton, Scientific Director, here with Dr. Pierre Tariot, Director of the Banner Alzheimer's Institute and Research Professor of Psychiatry at the University of Arizona College of Medicine, and Robin Martinez, a patient advocate who manages the online communities and patient engagement at Smart Patients Inc. This episode of Cognitive Conversations will discuss HCP patient communication regarding brain health and cognitive decline, with a focus on primary care settings. This podcast is part of our 2025 Brain Health Program, in partnership with Practicing Clinicians Exchange, Smart Patients, and the Society for Post-Acute and Long-Term Care Medicine, and supported by an educational grant from Lilly. Please visit the show notes for a link to our Brain Health Resource Hub containing many additional activities. Now let's get started and hear what our expert has to say.
Our guest today is Dr. Pierre Tariot from Banner Health in Arizona. And Banner Health has a unique approach to helping older people, well, anybody really, who has worries about whether their mind is functioning, their brain is functioning as well as it should be. And we call these problems typically mild cognitive impairment or brain fog, going up to moderate cognitive impairment. And people always wonder when they start feeling foggy, is this because of some medication I'm taking? Is this because I'm getting older? Is it just because I'm not paying attention? What can I do to make my brain health better? And I know that Banner has a really interesting approach to this. Could you tell us about that?
Sure. So Banner Health is a large nonprofit healthcare corporation that has the view that in the future, we should be managing health at a population level, population health management. In order to do that successfully, you have to be able to manage major chronic illnesses, including but not limited to cancer or diseases like Alzheimer's disease. So some years back, Banner Health birthed our Banner Alzheimer's Institute in a way as a learning laboratory to prepare for this challenge of managing people with and at risk for diseases like Alzheimer's that cause dementia. So we emphasized supporting our primary care clinics and colleagues because there aren't enough specialists to take care of everybody with emerging Alzheimer's disease and related conditions. So we went through a process of redefining the primary care workflow. And then we pilot tested that in 2 clinics enriched in Medicare beneficiaries. We call that the Dementia Care Initiative. And what we found in the first round, we focused on real-time case identification. You know, who in the clinic right now has significant cognitive impairment that should be worked up. We had rules for evaluating people. The rules worked so well that the clinics identified hundreds of people with possible cognitive impairment in just a matter of a couple of months and said, well, this is too much, we're overwhelmed. We revised that to just do this type of cognitive assessment at the annual wellness visit or if there was concern. The same thing happened. There were way too many people who were eligible for a full sort of brain health evaluation. So we pivoted to what we have now called Dementia Care Partners. And the gist of that is that we provide a navigator to families dealing with a person with dementia, often, but not always, Alzheimer's disease. And we support them over a period of months to learn how to adapt, to learn how to manage things better. And we also serve as the eyes and ears for the primary care doctor. So that's kind of it in a nutshell. As a corollary to that, the last thing that I'll mention is that we are one of several programs in the United States doing what's called an ECHO program. This is not telemedicine, it's telementoring. So over a period of months, we as specialists partner with mostly primary care doctors, but general neurologists and other health providers to help them learn how to evaluate and manage persons with suspected or actual cognitive impairment better.
what happens to the people who are just at that stage where they're worried? Or, I can never find my keys. What's wrong with me? I forget what I'm doing when I go into the kitchen. Why did I go in there? I can't remember my son's telephone number. Or the more scary one that happens to some people sometimes, and this one is a really dangerous sign, I got lost on my way home. So when you have people who are expressing this kind of worry when they come in to their primary care doctor, what happens? How alarmed is the doctor? And how does he find out the extent of the problem?
As we age, we generally do experience some change in our memory and other thinking ability. So, for instance, there's something called age-associated cognitive impairment that we want to know about, but typically don't worry about too much. So that's typically loss of memory, but only for words or names. It's transient, that the information comes back after a bit, or cueing helps. It could include diminished attention while they're competing environmental stimuli. So having a harder time concentrating if it's a chaotic environment. And then the third thing that we can see with normal aging is decreased processing speed. If the difficulties could go beyond that, then we start worrying about a phase called mild cognitive impairment, which has three fundamental criteria. The first one is concern. I, the patient, am concerned, or a loved one is concerned about me, or my healthcare provider says, hey, I've seen a change in how your memory and thinking ability is doing. So that's the first criterion. The second criterion is the testing of some kind. It doesn't need to be elaborate, but testing needs to be done and show objectively that there is loss of cognitive ability compared to age and education matched peers. And so it could be a simple office test. There's one called the MOCA, for instance, that's very commonly used. And so that needs to show a certain degree of decline in cognitive performance. And then the third criterion for mild cognitive impairment is absence of decline in the ability to function normally on a day in, day out basis. Finally, what is dementia? Dementia is changing cognitive ability that's getting worse over time, affects multiple domains: memory, learning, language, visual function, and so on, and is associated with loss in this ability to function on a day in, day out basis. So the healthcare provider is going to be wanting to think along those lines. What general bucket is this likely to be in? And so there would be questions about, what, if any, impact does this have on your day-to-day life? What else have you noticed? I would ask about neurological changes and so on, and almost definitely do an office test of memory and thinking ability. If somebody didn't have cognitive concern, but, I go in, I see my doctor, I'm in my 70s, it makes sense to routinely check how my brain is functioning. My doctor may do something called a mini-cog, ask me to repeat 3 words, table penny, for instance, then ask me to draw a picture of a clock with all the numbers, and then set the hands to a particular time, and then ask me those 3 words. And interestingly, that simple test, which takes maybe 2 or 3 minutes, if it's normal, there's a very, very good chance that my brain health is okay, and we don't need to go any further. However, the scenario you described as somebody who is concerned, in that case, I would advise the medical provider, the healthcare provider, to skip that simple test, because a negative result doesn't mean there isn't a problem, and go to a different test like I mentioned the MOCA, the Montreal Cognitive Assessment, which looks at the ability to remember, to draw, to speak. It checks one's orientation to space and time, the ability to understand images. You brought up that example before. That's about a 10 to 15 minute test and is quite useful for this objective assessment of whether somebody does or does not have decline in thinking ability that could be medically significant and require further evaluation.
How much weight does a relative's comments have? Say a person takes the mocha and they do maybe borderline, or maybe they do great, and the relative says, well, I'm still concerned because he keeps forgetting to turn off the stove and he can't put on his shoes and socks by himself anymore. Maybe that's physical. Maybe that's not remembering that socks come before shoes. And he keeps losing words and he does this and he does that. How much weight does other people's reports have?
Yeah, I'm really glad you brought that up, because if I'm the patient and I'm the sole source of information about how I've changed cognitively and functionally, I might not be a reliable reporter. So I would generally attach quite a bit of significance to what a loved one has to say. And you're describing somebody who may be sort of on the borderline with objective testing, but does in fact seem to have difficulty functioning in a normal way. And so my next job is figuring out, well, is there a medical problem causing that? That can be identified, like a vitamin deficiency, for instance, or could this be an early manifestation of brain deterioration due to something like Alzheimer's disease? So I would do a more extensive interview. I would do a focused exam looking for evidence, for instance, of stroke or Parkinson's disease. I would do routine blood tests. I would do brain imaging, looking for things like stroke or tumor. And that would sort of be the first milestone. Did that turn anything up that's identifiable and reversible?
What about assessment of the person's meds?
Absolutely. Yeah, that's a really big part of the medical evaluation. So many of us are on medications that impair cognition. And so, not to mention just medications, substances, alcohol, marijuana, whatever. So that would absolutely be part of the medical workup. You're absolutely right.
And antihistamines and so on that we don't think of as harmful, but as we age can really impair cognitive function.
Absolutely. And I've actually done some of that research myself. People are fond of taking diphenhydramine. It can help you fall asleep, but it has profound memory impairing effects. And we absolutely would suggest that person stop such a medication.
Now, I understand there's a new biomarker test that can tell from blood whether or not a person has certain protein buildups in their blood, abnormal proteins, that might indicate that they develop a problem. Can you tell us a little bit about that and when that might come into play?
Right. So right now it's May of 25. So in May of 25, the FDA granted approval for the first time for a blood test that, just as you said, has a fairly high likelihood of establishing whether or not there are Alzheimer's disease changes in the brain. It's recommended for use only in people who have cognitive impairment to begin with, not the worried well, not somebody who doesn't have cognitive difficulty. It's quite sensitive and specific, but it's not perfect. So there's a chance of intermediate or indeterminate results, which means you don't get the answer you want. So a definitely positive result is highly likely to be correct. Definitely negative result is likely to be correct. An intermediate result means you're not sure. And then the next step under specialty care would be a specific type of positron emission tomography scan of the brain or spinal fluid testing, which are more sensitive and specific than the blood test. This is the first blood test. There will be more for sure in the coming months and years.
But that test is only useful for Alzheimer's dementia. Is that correct?
That is correct. So if it doesn't show Alzheimer's changes, it doesn't mean that there aren't changes due to, for instance, to strokes or so-called Lewy body disease or Parkinson's disease and so on.
How reversible would you consider mild cognitive impairment to be? You see all these ads on online for play this brain game. It'll keep your brain healthy and, you know, recommended for older people and so on and so on. Are there things that people can do to improve their brain health?
The simple answer is yes, and we take them very seriously. Some people with, quote, mild cognitive impairment might reverse spontaneously to normal cognition. Others, as we've touched on briefly, may have any one of a number of medical issues that are the culprit, whether it's medication, substance abuse, sleep apnea, hearing impairment, nutrition. And then some people, however, progress to frank dementia over time. The majority of mild cognitive impairment folks will eventually progress, but not everyone. What can we do in the face of having something like mild cognitive impairment? All these medical things that we talked about are absolutely essential. And maybe, so for instance, my neighbor is worried about his memory and he had some testing. He meets mild cognitive impairment criteria and his Alzheimer's test was negative. So what they're focusing on is that he's hearing impaired. He's lonely. I'm not his doctor, but I think there should be concern about whether he might be experiencing actual clinical depression. He's way overweight. He's sleeping badly. He would admit that he's drinking more than he ought to. These are all things that if we focus on them might help him think and remember better. So those are examples.
That makes a lot of sense. And it's sad and frightening how many older people do end up entirely on their own. They get a call from their kids once a week or whatever, but they don't have a pet. They barely go out. They go out to grocery shop maybe or do an errand, but or go out to the doctor, but they don't go out socially, and they don't have the kind of friends that you see daily. How important is socialization and staying in touch with other people and other beings?
Yeah, it turns out that loneliness or isolation is a risk factor, not only for cognitive impairment, but many other health problems as well. I think the audience would want to know that an international commission on brain health issued an updated publication relatively recently identifying 14 risk factors for future dementia, many of which are tractable and become the focus of the conversation about how to optimize your brain health. Some of them can't be modified on an individual basis, like early childhood education or pollution, but many can, and they include isolation. They include diabetic changes, problems with cholesterol, hypertension, alcohol abuse, lack of exercise, and so on. And these are really important. I mean, we talk about these as being as important as medication. But let's say my neighbor, we do all of those things, and maybe they help for a while, but he ends up still progressing over time. So his mild cognitive impairment intensifies. His doctor might repeat this Alzheimer's test. And then at that point, if that became positive, my neighbor may wish to have a conversation with his specialist about the pros and cons of proceeding with new treatment for Alzheimer's disease causing mild cognitive impairment or even mild dementia. So there are new FDA-approved therapies that actually are used only for people who have cognitive loss and these elevated changes showing the Alzheimer's disease processes in the brain.
How much advantage do you see especially with your integrated system. How much advantage do you see in having the primary care doctor involved in the process of assessment and noticing these changes in people?
Oh, I think it's absolutely critical. If we put all the specialists in the United States together, we couldn't take care of more than about 10% of people with suspected cognitive impairment or MCI, mild cognitive impairment, or dementia. So we really need to work together with our primary care colleagues and systems to be able to sort of be the upper part of the funnel. Um, be at the front lines and identifying who does or does not have emerging cognitive impairment. If they don't, no need for specialty care. If they do, is it one of the medical problems that I, as a skilled primary care doctor, a sort of specialist in general medicine, so to speak, is it something that I can deal with, like the sleep apnea, obesity, diabetes, hypertension, elevated cholesterol, and so forth? And only for the people who don't have one of those identifiable culprits would we then think about possible specialty care and these tests that establish the presence or absence of Alzheimer's disease. And now we have this blood test, which is amazing. It remains to be seen when and if it will be incorporated into the primary care workflow. The initial recommendation is that it be used by specialists, but I think that will change over time. But at the very least, for my neighbor who's progressing, his primary care doctor could order that blood test as part of the referral to a specialist, so that by the time my neighbor shows up with a specialist, the answer is there to a certain degree anyway about the presence or absence of Alzheimer's.
Of course, everybody who has concerns about their brain health, they're concerned at the mild level, but their overwhelming concern is, what if this gets worse? What if I develop dementia? And with the lack of specialists and the lack of care, it really is necessary for all of us to be concerned about preventing as much as we can prevent of mental decline, other than taking better medical care of yourself. What do you see in better socialization? Are there things that people can do that can help their brain health?
If I were to reduce it to one sentence or one phrase, it would be that a heart healthy lifestyle is a brain healthy lifestyle. So
That's great.
yeah, so the better you take care of yourself, particularly in middle age, the better your brain health is going to be in the long run. So exercise is critical. Controlling blood pressure, cholesterol, diabetes is critical. What you eat is critical. We often use the example of the Mediterranean style diet. Stopping smoking. Don't be a professional boxer. You use it or lose it. In other words, intellectual stimulation helps. We talked about social stimulation. We are social creatures. It really matters that we stay connected with people. Cut down the booze. Make sure you can hear and see okay. Make sure that your sleep hygiene is adequate. And again, stay connected with others. Keep your Rolodex up to date.
Question about sleep hygiene. Does it matter when you sleep? And is it okay to shift your sleep schedule to sleep when you're able to sleep?
In general, when we talk about sleep hygiene, it's very basic things like no caffeine after lunchtime, no alcohol within 3 hours of going to sleep, getting exercise during the day to the extent that's realistic anyway.
Avoiding screen time.
Avoiding screen time for at least an hour before bedtime. We actually encourage people to not even have a television in the bedroom. A routine schedule, sleep-wake schedule seems to be very important. And making sure that you're sleeping in a cool environment.
Pierre, thank you so much for talking to me. This has been really informative, and there certainly is a lot to consider in the whole field of brain health. I hope that with these tips and information that people will be able to take some of the load off specialists and preserve their own brain health.
I hope so too, and I hope I can inject a sort of sense of optimism for our primary care colleagues. Our patients and families are very concerned about brain health issues. Not everybody, but many, I would say most, are. And it becomes a rather large and satisfying part of primary care practice to be able to be confident in dealing with these issues, at least up to a point.
Knowing that there is some help out there is inbound. Thanks again for talking with us today.
Thank you, Robin. Appreciate it.
Thank you very much, Pierre and Robin. And thanks to you, the listeners, for joining us. Please look for 4 other companion podcast episodes discussing cognitive conversations in other clinical settings. As a reminder, to visit our full Brain Health Resource Hub, please click on the link in the show notes. As always, thanks for listening.